Hello everyone, this is Evangeline. I'm a midwifery student, second year, section A. In this video, we're going to talk the repair of perineal laceration. In suturing the laceration, there are three techniques that are commonly used. And there are, first, simple interrupted suture. Second is the continuous suturing, and the last one is the continuous interlocking suture. These are the materials that we will use for suturing. We have surgical needle, chromic, 2-0, half circle, round bodied. We also have tissue forceps, artery forceps, needle holder, stitch scissors, drapes, antiseptic, anesthetic. We're gonna use lidocaine, then the disposable syringe, it's 10 ml or cc, cotton balls, and the last one is the sponge that we will use for demo. The general principles of perineal repair is first, woman should be in a comfortable lithotomy position. The use of good light is very necessary. Next is the proper presentation of the anatomy through careful examination of the vagina, perineum, and cervix to assess the extent of the laceration. If the tear is long and deep through the perineum, inspect to be sure there is no third or fourth degree tear. Place a gloved finger in the anus. Gently lift the finger and identify the sphincter. Feel for the tone or tightness of the sphincter. Point number 1. If the sphincter is injured, we need to refer to the physician. Second, if the sphincter is not injured, then we will proceed the repair. We need the antiseptic techniques by wash and scrub hands, use gloves, correct cleaning techniques of the wound from the above downward using each swab once only, etc. Gently handling of tissue. Next is careful use of swabs or sponges so that none are lost in the vagina. Use of local anesthetics should be injected early enough to take effect before the start of suturing, like at least 2 minutes. The last one is explanation and sensitive approach to the woman during the procedure. Here are the steps in perineal repair. First, getting ready. Prepare the necessary equipment. Tell the woman what is going to be done. Provide emotional support and reassurance. Ask about allergies to antiseptics and anesthetics. Wear gloves, cap, mask. Use antiseptics, hand rub or wash hands thoroughly with soap and water, and dry with a sterile cloth or air dry. Put on high-level disinfected or sterile surgical gloves on both hands. Last, inspect the tears to be repaired. Identify the apex in the vagina, the hymenal tag, the junction, and the vaginal mucosa, and the outside skin. The wound edges and the perineal apex of the tear. These are the important landmarks for correct repair. In administering the local anesthetic, we need to clean the perineum with antiseptic solution. Next is fill the syringe with 10 ml of lidocaine. Insert the whole length of the needle beneath the vaginal mucosa and beneath the skin of the perineum. Next, aspirate by drawing the plunger back slightly to make sure that the needle is not penetrating a blood vessels. If blood is aspirated, stop. Remove the syringe with the needle. If lidocaine is injected into a blood vessel, it can cause heart irregularity, seizure, and death. If no blood is aspirated, then we will proceed. Inject the lidocaine solution into the vaginal mucosa, beneath the skin of the perineum, and into the perineal muscles. Wait for 2 minutes, then pinch the incision site with forceps. If the woman feels the pinch, wait 2 more minutes, then retest. Suturing the laceration. There are different suturing techniques which can be used to suture perineal laceration. First, we will do the simple interrupted suture. The interrupted suture is the most commonly used technique in wound closure. It is name derived from the fact that the individual stitches are not connected. Sutures performed with these techniques have the advantage of being easy to place and have a high tensile strength. In addition, individual sutures can remove without jeopardizing the closure. However, they require a relative long time to be placed, and as each suture requires its own knot, are a greater risk of inducing infection. The procedure of interrupted suture. First, start in the middle of the wound. Place suture at 1 centimeter interval until wound is approximated without tension. For each suture, grasp and invert the skin edge gently with non-dominant hand. Pronate the dominant hand so that the needle will pierce perpendicular to the skin and drive the needle through the skin by supinating the hand before picking up the needle. 2/3 from the tip. With the needle holder, a no-touch needle technique is important, reducing sharp injury and infections risk. Finish by carefully gathering the thread to create a long thread with needle and short thread before performing a hand with separate suture to close the wound. suture. The next technique that we will do is continuous suturing. In the continuous suture, the stitches are connected along the wound. This technique tends to be faster, particularly for long wounds. However, the wound is at greater risk of splitting or bursting if the suture material breaks. The procedure for continuous suture is first, start at the wound edge and work along the wound. For each suture, grasp and invert the skin edge gently with non-dominant hand. Pronate the dominant hand so that the needle will pierce perpendicular to the skin and drive the needle through the skin by supinating the hand, using the curve of the needle. Before picking up the needle, 2/3 from the tip with the needle holder. A no-touch needle technique is important, reducing sharp injury and infection. Next, place the suture as above at 1 cm interval until wound is approximated without tension. Carry this on a long wound. Finish carefully by gathering the thread to create a long thread with needle and short thread before performing a hand tie or instrument tie. Important note: care should be taken to apply the correct amount of tension to the suture materials. If too much, the skin becomes strangulated. If too little, the wound edges may not be opposed correctly. suturing. The last technique that we will perform is the lock suture. This is a locking variation of the standard running suture used for epidermal approximation. It may be used alone in the context of small wounds under minimal to no tension, such as those formed by traumatic laceration. It is generally used as secondary layer to aid the approximation of the epidermis when the dermis has been closed, using a dermal or other deep suturing technique. The technique is, first, the needle is inserted perpendicular to the epidermis, approximately 1/2 the radius of the needle distant to the wound edge. This will allow the needle to exit the wound on the contralateral side at an equal distance from the wound edge by simply following the curvature of the needle. Second, with the fluid motion of the wrist, the needle is rotated through the dermis, taking the bite wider at the deep margin than at the surface of and the needle tip exits the skin on the contralateral side. Third, the needle body is grasped with surgical forceps in the left hand and pulled upward with the surgical forceps as the body of the needle is released from the needle driver. Alternatively, the needle may be released from the needle driver, and the needle driver itself may be used to grasp the needle from the contralateral side of the wound to complete its rotation through its arc, obviating the need of surgical forceps. Fourth, the suture material is then tied off gently with care, being taken to minimize tension across the epidermis and avoid overly constricting the wound edges. This forms the first anchoring knot for the running line of suture. The loose tail is trimmed and the needle is reloaded. Fifth, starting proximal to the prior knot relatively to the region, steps 1 through 3 are repeated.